Okay. Good day, everyone. We have the ninth edition of ACL injury as part of Learning Basic Arthroscopy program. We are covering all small topics one at a time for the learners and the experts alike. So today we have Mr. Tahir Mahmud. He is consultant orthopedic surgeon and sports medicine surgeon in Manchester, the United Kingdom. We welcome, sir. Thank you for accepting the invitation to deliver your lecture.
Thank you. I'd just like to say thank you to Srinivas and Sasi for inviting me to take part in this lecture series. I've been asked to discuss the clinical assessment and presentation of anterior cruciate ligament injuries. And so what I'm going to do is today just talk through the presentation of ACL injuries, how we clinically assess them, particularly with a history and with a fine and accurate clinical examination, and how we can correlate some of those clinical and examination findings with what we see at the time of surgery as well, and how we can potentially influence our decision-making process further in terms of treatment of these injuries. So we all know the anatomy of the knee, but in particular, there was a very nice presentation a couple of days ago on the MRI diagnosis of anterior cruciate ligament injuries. I don't want to repeat too much, but as we all know, the anterior cruciate ligament is a ligament that's comprised of predominantly two bundles, an anterior medial bundle and a posterior lateral bundle. The anterior medial, these bundles and their location are referenced according to their origin of the tibia. The anterior medial bundle runs more front to back, and so it controls anterior posterior translation of the tibia on the femur, compared to the posterior lateral bundle, which runs a little more obliquely and is responsible for contributing more to controlling internal rotation of the tibia with respect to the femur, so controlling in part the pivot shift as well. So here we are with a cadaveric dissection of those bundles, both on the tibia, looking from above. We can see a large footprint of the AM bundle, and we can also see a cross-section through the lateral wall of the intercondylar notch, and we can see the footprint for these bundles on the femoral side as well. This helps us understand how each bundle works with respect to controlling anterior translation and controlling internal rotation of the tibia. So this is a arthroscopic video at the time of ACL surgery. We see the PCL at the back, and essentially I'm just identifying the bifurcate ridge here, which is a bony landmark which we use to delineate the AM bundle and posterolateral bundle insertions, and to help us identify where we're going to place our femoral tunnel. So in terms of anterior cruciate ligament injuries, they mostly occur 70% roughly from non-contact injuries. They can also occur from contact injuries. So non-contact injuries usually result from a sudden deceleration and change in direction. So the foot is planted on the floor and the person is turning away to the side with the foot planted, applying a slight internal rotation to the tibia and possibly a valgus stress to the knee, which ultimately results in rupture to the anterior cruciate ligament. It can also occur due to hyperextension or over-straightening of the knee joint, which can occur, for example, in sports where people jump and land, and if they land incorrectly or land with their foot not positioned in the right place, the knee can hyperextend, resulting in rupture of the anterior cruciate ligament. Obviously, they can occur from contact injuries as well, and usually in the context of a contact injury, they can be associated with other associated soft tissue injuries as well as the ACL. How often do they occur? Well, in the US, they roughly occur 1 in 3,000 people. They're more common in females than males, and there may be intrinsic factors and such as the Q angle, which is greater in the female, a slightly narrower intercondylar notch, which can result in impingement of the anterior cruciate ligament, increasing chance of rupture, increased joint laxity, possibly in the female population, and hormonal influences as well. There are extrinsic factors like less muscle bulk, less muscle strength, different muscle firing patterns, different landing patterns as well, which can contribute potentially to increased risk of injury to the ACL in the female sporting population. The history is very important, just like it is in any part of medicine. I would say, 90% of your history of, or diagnosis of a anterior cruciate ligament injury is from your history. The mechanism, again, you will ask, is it a contact or non-contact mechanism? It's important to really take time, go into detail, as to what they were doing. Were they playing sport? What sport were they playing? Were they playing on grass? Were they playing on an artificial pitch? We know that certain astroturf and artificial pitches are associated with a higher incidence of anterior cruciate ligament rupture compared to playing on grass. Were they wearing proper footwear? Were they wearing football shoes with cleats, or did they have non-sport specific shoes? These can influence the injury. Did they hear a popping sound? A popping sound or a snapping sound is pathognomonic really for an anterior cruciate ligament rupture. Most people will tell you, doctor, I was running and I was playing football and I was changing direction and I heard a pop. When they tell you they heard a pop, straight away, you have to have a very high index of suspicion for an ACL injury. Yes, it can be something else, such as a meniscal tear, and occasionally it can be a dislocation of the patellofemoral joint, but often it is a ACL rupture. These injuries are very painful. It usually marks the end of that sporting activity. So you ask them, were you able to continue playing? And they will tell you, no, they couldn't play. They were lying on the floor. It was extremely painful. Usually they cannot stand up and weight bear on the knee because it's very sore. And they have to be helped off the pitch, often carried off the pitch. So all of these bits of information that you can get from the history are very important in helping you to initially raise your suspicion for an ACL injury. If they heard a pop, but they continued playing for another 45 minutes and the knee didn't swell particularly much initially, it could be a meniscal tear, for example. So it's important to use the history and the information to help make the diagnosis. Swelling is very important. We all know that a hemarthrosis occurs usually within the first few hours following an ACL rupture. It's usually quite immediate compared to meniscal injuries, which can swell. Often the patient notices the following day their knee can be swollen. So does the knee feel unstable? The patients don't usually use the word the knee was unstable, so it's important to use terminology that the patient may relate to, such as, do you trust your knee? If I ask patients, do you trust your knee? They will say, no, doctor, I don't trust it. I feel like it may give way. So it's important not to use technical terms, but try and explain the symptom in a way that the patient can relate to. Locking is important as well with certain soft tissue injuries like a bucket handle tear of the meniscus, which can occur concomitantly with an ACL injury. The knee can be locked as well. So it's important to ask specifically if they have had a symptom of the knee locking. So what happens when you rupture your ACL? Well, ultimately, it is a pivot injury. And a pivot injury means essentially that if we look at this diagram, I think it explains it very nicely. So in this diagram, we're looking at a right-sided knee. And if we talk ourselves through the steps of an ACL rupture, the first thing is we're looking at from A to E. We'll start with A. So A refers to the fact that the right foot is planted on the floor and the right tibia is internally rotating. So you can imagine this person is maybe running and they're suddenly slowing down very rapidly and they're changing direction. Their right foot is leading in front of them and they are turning to their right-hand side. So when they turn to the right-hand side, their tibia A internally rotates. So when the tibia internally rotates, the femur externally rotates, and that's what's happening on B. When the femur externally rotates, it can potentially sublux off the lateral side of the tibia. And that results in C, which is the impaction injury. And we see this, as you were told on the MRI discussion, it's represented as bony edema on the lateral femoral condyle and posterolateral tibial plateau on the MRI scan with acute ACL injuries. And that's the mechanism for that bone bruising. Ultimately, this is a valgus stress injury as well. The knee goes into valgus, which leads to strain and stretch on the medial collateral ligament, and that is D. And often on the MRI, again, we see signs of a grade 1 or a grade 2 medial collateral ligament sprain. The final thing to go is E, which is the ACL rupture. So depending on where that person is in that cycle of events, they can have multiple injuries, ultimately leading in rupture to the ACL as well. So it's important to be aware of associated patterns of injury with when you rupture or injure your anterior cruciate ligament. The ACL may be fully ruptured. it could be a partial ACL tear, so a tear of one of the bundles of the ACL, not both bundles. There may be associated injuries, particularly with contact injuries, such as posterolateral corner injuries. There can be meniscal tears, and studies show that up to 50% of ACL injuries are associated with an injury to the meniscus. This can either be a medial or a lateral meniscal injury, and the lateral meniscal injuries are more common at the time of an ACL rupture than medial meniscal injuries. There can also be injuries to the meniscotibial ligament, and these are referred to as ramp lesions, and these have been described quite extensively in the last few years, and the treatment for these injuries has also been described. The anterolateral complex, so for example, the anterolateral ligament is an important contributory factor to stabilizing rotational instability and preventing it. And so injury to this complex, again, can result in quite significant rotational instability of the knee. And again, we can have joint surface injuries as well. So it's important to be aware that you can damage the articular cartilage and underlying bone, and you may have an osteochondral injury as well. Chondral injuries are very common at the time of ACL and pivot injuries. Osteochondral injuries are less common. So clinical examination, really I want to focus predominantly on how we assess for an ACL injury. So, in orthopedics, we keep things pretty simple. It's always important to assess the gait, and you will see these patients often will be limping into your office because they are in pain. They may be on crutches, they may have a knee brace or some support on the knee. Essentially, the gait isn't normal in the early stages. They may also be walking with a locked knee or a knee held in flexion because there is a difficulty in that patient getting their knees straight, possibly due to pain, maybe due to the hemarthrosis, or possibly due to impingement of a structure such as the ACL stump that may be ruptured, or possibly a bucket handle tear of their meniscus. It's important to assess for an effusion. An effusion is present in the early stages following an ACL rupture, and it usually implies there's a hemarthrosis and can give you a high index of suspicion that there is an internal injury within the knee joint. It's very important to assess range of motion in the knee joint. Not only do you want to ensure these patients get their full range of motion back, particularly if you are planning to reconstruct the knee has to be in full extension with good flexion. Otherwise, if you operate with a knee that's not straight, you will capture that knee in flexion and the patient will never get their knee straight and they will not be happy in the longer term. It's important to assess the patellofemoral joint. I do acute knee clinics, as I'm sure some of you guys do as well. And you will know that a lot of patients referred to your clinic with ACL rupture actually have dislocated their patellofemoral joint and vice versa. So it's often mistaken for patellofemoral instability can be mistaken for ACL rupture and vice versa. So just pay some attention, particularly to the patellofemoral joint. So going on to special tests, well, for the ACL, we have 3 tests: the anterior draw, pivot shift, and the Lachman. So we're going to talk about those in a little bit more detail. I just wanted to demonstrate an effusion. I'm sure everyone knows how to do this, but if we look to the right-hand side of the screen, I do a swipe test, and we will see that there's a bulge just to the right-hand side, a little fluid thrill indicating that there is an effusion in this knee, okay? So special tests for the ACL, as I mentioned, there are 3 tests. If we look at the research that has been done on these tests in terms of looking at predictive values, looking at sensitivity and specificity, we will see that based on predictive values alone, a negative anterior Lachman test is the best test for ruling out an ACL injury. So if your anterior Lachman test is negative, then you almost certainly haven't ruptured your ACL. If we look at the pivot shift test, if it is positive, then compared to the normal uninjured knee, then you almost certainly have injured your ACL. The anterior draw test, we all do it for completeness, but it has a low specificity and a low sensitivity. Often I find sometimes you can examine an ACL injured knee, the Lachman is positive, the pivot shift test is strongly positive, but the anterior draw test is positive, but not as positive as you would initially have expected it to be. So if we break down the anterior Lachman, what are we doing with an anterior Lachman test? Well, we're testing predominantly the anterior medial bundle of the ACL for anterior translation. This test has roughly a 94 to 98% sensitivity, depending on the literature that you read. It's important to realize and appreciate that you're not testing for rotational instability, i.e. the posterolateral bundle, or the influence of the anterolateral ligament complex. You're just testing the anteromedial bundle. In order to do this, we hold the knee in 15 degrees of flexion and we translate the tibia anteriorly, and we look for a soft feel, or what we call a boggy endpoint, a soft endpoint, not a good firm endpoint. And I'll show you, demonstrate this to you in a moment. If we then look at the pivot shift test, well, this is a dynamic test as well. It demonstrates axial and sagittal stability because of the way the test is performed, and I will demonstrate that to you. It was first described by Galway in 1980, and it is the most specific test, as I mentioned before, for ruling in a anterior cruciate ligament injury, and it essentially tests for anterolateral rotational instability. It's important to also appreciate that the pivot shift test, it can be positive and multifactorial. There are many factors that can contribute to a positive pivot shift test, not just the rupture of your posterolateral bundle, but there could be a complex meniscal injury. So we know that the menisci are obviously they're shock absorbers, but they have many other functions, of which secondary stabilizers of the knee are an important function. So if you have significant meniscal injury as well as your ACL, it can contribute to a larger positive pivot shift test. Ramp lesions, again, can contribute to having a strongly positive pivot shift, and that should raise your index of suspicion, and also the bony morphology of the knee. So patients who have increased tibial slope, say more than 9 degrees, are likely to have 9 degrees in the sagittal plane, are likely to have a greater pivot shift test compared to someone who has less of a tibial slope. So these are important considerations just to be aware of. So what is actually happening during the pivot shift test? So essentially what's happening is we're reproducing the pivot that happened when the patient ruptured their ACL. So we've already been through the mechanism of the injury. So when we're performing the test, essentially what we're doing is we're subluxing the anterolateral tibia forward or anterior with respect to the lateral femoral condyle. And as we're flexing the knee, the tibia reduces back underneath the femoral condyle. And that happens by the iliotibial band that is attached to Gerdy's tubercle actually pulling the tibia posteriorly. So we're going to look at that in a little bit more detail in 1 second. So in order to produce or perform a pivot shift test, you have to have 3 things. That you have to have a knee that you can get close to full extension, certainly no more than 15 degrees of knee flexion. Otherwise, it's very difficult to elicit a positive pivot shift. You need to have intact medial collateral ligament because you will be applying a valgus stress to the knee joint. And you must have an intact iliotibial band because it is the iliotibial band that is reducing the tibia back underneath the lateral femoral condyle where it needs to be. So I'll demonstrate this with a video, but I'll just talk you through it. We will start with the knee in full extension. We will internally rotate the tibia to sublux the anterolateral tibia with respect to the femur. We're going to apply valgus stress, and then we're going to flex the knee. And when we get to around 30 degrees of flexion, we can see a palpable clunk. The word to describe that movement is a clunk, and we can see a clunk when we get to around 30 degrees as the knee joint reduces back to its normal position. So how do we grade pivot shifts? Well, there's the International Knee Documentation Committee grading system, which is actually 0 to 3, but I've put 0 to 2 here, and I'll describe this to you. 0 is normal. There is no pivot shift. 1 is there is an abnormal movement, but it's not a rough clunk, but it's more of a glide. But it's an abnormal movement, but it's not a sudden movement. And then grade 2 is a sudden large clunk. They have graded 3 as well, which I've not put here, but it implies that there's a persistent subluxation of the knee. So the first thing we do when we get a patient with a ligament injury into the operating room is to examine their knee under an anesthetic. This is the most important part of your operation because it helps you confirm the pattern of ligament injury, but also assess the severity of your laxity. And you can get a better idea when the patient is completely relaxed as to how you can grade their pivot shift test. You can perform pivot shift tests in clinic, and most of the time I'm able to get a positive pivot shift out of a patient who is awake and has an ACL injury, although it can be difficult sometimes because patients become apprehensive and anxious because when you are trying to do the test, it reminds them of the time that they injured their knee and they feel very anxious. So the best place to do this is in theater. So in this video, I'm going to run through very quickly how I do a manipulation under anesthetic, not just assessing the ACL, but assessing the collaterals and the posterolateral corner as well. So it runs pretty quickly, but I'll try and talk you through. If we need to see it again, we can if necessary. So the first thing I'm doing is checking the range of motion in the knee joint, okay? And comparing to the other side, the normal side. So good full extension, full flexion. Then we do an anterior Lachman. Okay, there's a good, strong anterior Lachman. And I'm going to do the anterior draw, and we're going to first of all, feel the anterior medial tibial step off to make sure there is no posterior subluxation of the tibia, which we will get with a PCL injury. And now we're going to do a pivot shift. So we start an extension and we go to about 30 degrees of flexion and we see a positive clunk there. Then we test the MCL, medial collateral ligament in extension and 30 degrees of flexion. We assess the lateral collateral ligament, and I like to palpate it with my finger in the figure of 4 position. And then we'll do a dial test, which is what I use for the posterolateral corner in 90 degrees and 30 degrees. And we're looking for increased external rotation of more than 10 degrees on the injured side. At 30 degrees, we get a better appreciation of the posterolateral corner if it's injured, and at 90 degrees, if it's positive, it could also be a PCL injury. So it's important to be aware of that. So if we just focus on the Lachman again in more detail, so this is an anterior Lachman, again, an examination under anesthetic. We can see there's a significant anterior translation with a boggy endpoint. And again, we're going to do the pivot shift, starting in extension, internal rotation of the tibia, a valgus stress, and we flex the knee. And we can see there's an obvious clunk there. Now we're going to look at the knee on sideways, and we're going to appreciate this clunk even more. And you can also see the iliotibial band and how it is acting to reduce the tibia. So, the effect of eliminating the pivot shift can be quite significant following ACL surgery. So as the graft has been deployed, this is the same knee. And, there's a smooth transition now from extension to flexion. We do not have any abnormal rotational movements, and the Lachman has been restored. So I'm just going to mention the anterolateral side of the knee very briefly because it has a significant impact on rotational instability of the knee. This is a cadaveric dissection demonstrating with the arrows pointing to the anterolateral ligament, which runs from close to the lateral epicondyle to a point halfway between the fibula head and Gerdy's tubercle. And we also see the iliotibial band coming in, going over the top of the lateral collateral ligament. So with big pivot shifts, with grade 2 pivot shifts, of big explosive clunks, particularly in patients who are getting back to pivoting sports, or patients who have hyperlaxity, for example, or there's good evidence now from randomized controlled trials from Al Getgood and his team demonstrating that, particularly in younger patients who are having hamstring autografts, it's worth considering doing a lateral procedure. My procedure of choice is a modified Lemaire using the iliotibial band. And essentially we end up with a graft of iliotibial band passed under the lateral collateral ligament, which is passed into a socket on the lateral femoral condyle and then fixed with the knee in 60 degrees of flexion and neutral rotation of the foot. And this really helps control both the anterior translation and rotational stability. Yes, there are concerns about over-constraining the lateral compartment, which may theoretically lead to increased lateral compartment wear over time, although it's recommended that you do not over-constrain, and approximately maximum 20 newtons of force should be used when you're tensioning your graft. So that brings me to the end of my presentation on the clinical presentation and assessment of anterior cruciate ligament injuries. I'm very happy to take questions.
Thank you, Doctor. It was a wonderful presentation. It was crisp and clear regarding the mechanism of ACL, how you have to identify it, based on the history and also the steps needed in the clinical assessment of ACL injuries. I particularly loved that slide where you showed the mechanism of ACL injury with bone models and also the associated injuries that happen along with an ACL injury, the internal rotation of the tibia, the external rotation of the femur, the posterolateral compression injury, the valgus force on the medial side. That was a beautiful slide. Thank you for
Thank
putting
you.
it up.
No problem.
Mm, there are a couple of questions I would like to ask. Okay, with respect to the clinical assessment, you were talking about Lachman and anterior drawer test. Do you
Sorry,
specifically
sorry, Sasi, can you repeat that? The Lachman and the
and the anterior drawer test?
anterior draw test, yes.
Yeah. I would like to ask whether you can also use these tests to specifically identify which bundle of ACL is injured.
That's a very good question. So, as I was trying to explain, the anterior Lachman tests for the anteromedial bundle more, because if you look at the, if you remember from my slide where I demonstrated the anatomical position of the AM bundle, it runs more from an anterior to a posterior direction. So you can imagine it's going to control this movement better because it's running straight. So if you have a positive Lachman, it almost certainly means that you have ruptured your anteromedial bundle. I'll be honest with you. I don't think it's possible to, on clinical examination, say with 100% certainty, this is an AM bundle injury or this is a PL injury. However, there certainly are patients who have a relatively normal Lachman, but they have rotational instability. So in those patients, you have to have an index of suspicion that they must have injured their posterolateral bundle, or possibly they may have sustained an injury to the anterolateral side of the knee. Or, as I mentioned before, there can be other associated injuries in the knee that can contribute to rotational instability, such as a meniscotibial ligament injury, like a ramp lesion, or a significant meniscal tear, a root avulsion tear of the meniscus. So these injuries can also cause rotational instability. So it's important to consider those, but to be absolutely honest with you, I don't think you can be 100% certain from your examination. What you can conclude, however, is that there's likely to be an injury to the ACL. But that's when we really rely on our imaging, which is an important part of the diagnosis and exclusion of associated injuries. So the MRI will give you a good MRI reported by an experienced radiologist will be able to tell you whether this is a complete rupture or a partial bundle rupture, and they often report the MRI scans as such. But clinical correlation with that is important. So, like I said, increased anterior Lachman, probably AM bundle, certainly. Whether PL bundle is gone or not, I don't think you can say. But if you're rotationally unstable, then certainly your posterolateral bundle has gone, and there may be some other associated injury as well. I hope that helps explain.
Yeah. In addition to answering my question, you also added a lot of other points. So, at sometimes even I have noted that, but I do agree with you that it is not exactly the clinical assessment may not be exactly perfect, especially when the patient has a lot of pain. But
Yes.
sometimes when the patient is comfortable and you are clear in what you are assessing, for example, there is a positive Lachman and a negative anterior drawer, or vice versa, you may be able to try to think of the permutations and combination that could have happened, especially with a positive Lachman but a negative anterior drawer. It could mean an anteromedial injury with an intact posterolateral bundle, and vice versa. That could be a posterolateral injury with an intact anteromedial injury. And thank you for pointing out that rotational instability most likely points towards a posterolateral bundle injury. Okay, so that's again a very important point that you have mentioned. Thank you. And okay, at some point in your presentation, you said that ACL injuries are commonly associated with lateral meniscal injury. I want you to talk more on it.
Okay.
Isn't ACL injury more associated with a medial meniscal injury, especially in the acute setting, and lateral meniscal injury more common in the chronic ACL injury?
Yeah, I think, historically, I think we were taught that, there was a terrible triad of injuries, with ACL rupture. So you had an ACL rupture, an MCL injury, and a medial meniscal injury. But actually, I think over time with research and following up these patients, I think, the literature is quite clear now that, yes, you can injure your medial meniscus, you can injure your lateral meniscus. However, in the acute setting, the incidence of lateral meniscal tears is more than medial meniscal tears. There's no doubt that sometimes, we do see, a medial meniscal injury and the lateral meniscus is intact. So it's not an exact science, but I think certainly you have to have an index of suspicion for both. But certainly I have to say I do perform more acute lateral meniscal repairs, anecdotally with my ACL reconstructions than I do medial meniscal. What I do find in with chronically injured ACLs, you can sustain a bucket handle tear to either of your menisci, from chronic instability. So I think certainly in the acute phase, yes, you can injure both. Both do get injured, no doubt. I'm not suggesting you don't injure your medial meniscus, but in the acute setting, from the literature, it supports that the lateral meniscus is injured more commonly than the medial, but you can injure either or. I think that's the key thing. It's not that you don't injure the medial meniscus, but in terms of the incidence, the lateral meniscal injuries acutely are greater than the medial ones.
Okay.
I'd
like to ask
the medial injuries are more common in chronic.
Absolutely. So the medial injuries are absolutely more common in the chronic setting, absolutely. And if you think about the mechanism of injury, it's not difficult to really appreciate why that is the case. So going back to that diagram, Sasi, you were referring to on the mechanism of the injury, if you think about the lateral femoral condyle subluxing off the tibia, as it goes, it's dragging the lateral meniscus with it. So, it predisposes that lateral meniscus to excessive stress and strain and trauma, and it's more likely to tear, even though the lateral meniscus is more mobile than the medial meniscus.
Yeah. On the other hand, the medial meniscus is larger, so possibly it has a larger stretching capacity, while the lateral meniscus, with being smaller and being attached within a smaller area, possibly, it's theoretical, but that could be one of the reasons. I would like to ask you a hypothetical question.
Sure.
If you have a patient with a partial ACL tear and you have to decide on a conservative treatment for him, will the diagnosis of whether the anteromedial bundle is torn or the posterolateral bundle is torn decide whether you can proceed with a conservative treatment? And is it also affected by the occupation of the patient, for example,
Sure.
sports?
Yeah, so that's a good question. So I spend a lot of my time speaking to my patients, which is unusual perhaps for orthopedic surgeons, but it's important to really understand your patient, fully. So understand the personality of your patient, understand your patient's expectation, because ultimately poor results with ACL surgery are usually because we haven't really understood the patient or we haven't met their expectations. So the first thing I will ask my patients, obviously occupation is really important, but also what are their expectations? Are they expecting to get back to multi-directional pivoting sports? If they are, then perhaps my threshold for offering them ACL reconstructive surgery after some prehabilitation may be slightly lower. I may be more likely to offer them surgery. However, I think the important thing for me is seeing whether your patient actually needs to have an operation. So if there's someone who likes to do straight line activities, so they're a walker, they're a runner, they like to cycle, they like to swim, occasionally they might play some sport like badminton or squash or tennis, but most of the time they're not, then regardless of whether I felt the AM bundle or the PL bundle was ruptured, I would put them through a very good lengthy course of physiotherapy, okay, to build up their quads, their hamstrings, their gluteal muscles, to work on proprioception. And I'd really see whether we're able to then introduce some cutting maneuvers for them, and if they tolerate that. And if they tolerate it well, which some people do, we can potentially avoid surgery. I think having an ACL rupture doesn't mean you have to have an operation. So there are some patients who tell you straight away, oh, I need to get back playing football. Football's my life, and those patients usually are very motivated. So they will do their physio very well. but they are still likely to require reconstructive surgery, particularly if they have a very big pivot shift. So I think the pivot shift is the key thing rather than the Lachman. So the rotational instability appears to be the bigger factor in whether you're going to offer them an operation rather than the Lachman, the AP instability, because the AP instability they can control doing straight line activities, but when they try and turn on their injured leg, if it's rotationally unstable, I think, that would be an indication for me to offer them surgery. So, sometimes straight away whether someone is heading towards an ACL, whereas others, I think we can potentially avoid it. So I take the individual patient's expectations into consideration, but also my decision-making process is guided by the clinical findings. So if they want to get back to playing football, but they have a massive pivot, then I think, they're going to need an operation probably. I hope that answers the question.
I think that's a very beautiful answer. Thank you very much.
No problem.
It did. Dr. Srinivas, you want to ask something?
Yeah, thank you, Tahir. The presentation was very good. Thank you very much. Can you just tell us about the grading? Is there a grading for Lachman and anterior drawer tests? And also about the endpoints. So what does soft endpoint mean? What does a hard endpoint mean?
Sure. Yeah, that's a good question. And yeah, you're right. I didn't really go into that in my talk, but so the grading for anterior Lachman and anterior drawer is based on the degree of translation of the tibia with respect to the femur. So that's graded in 5mm increments. So up to 5mm of anterior translation is described as a grade 1. Up to 1 centimeter or 10mm of translation is a grade 2. When we are able to translate anteriorly the tibia 15mm, then that is considered a grade 3. Remember, it's always important to compare the injured side with the uninjured side. So if on one side you're able to translate 1 centimeter, but on the normal uninjured side, it's half a centimeter, you have a grade 2 Lachman on the injured side and a grade 1 Lachman on the uninjured side. The same thing corresponds to the anterior drawer, exactly the same. So the endpoints, now we talk about a hard endpoint and we talk about a soft endpoint. So a hard endpoint means that when you translate the joint forward, you get a really firm resistance to further movement. It's a really solid end. You can't move it and it feels really good. Whereas with a soft endpoint like that video of the anterior Lachman I showed you, you could see that tibia was coming forward a long way. And when we get there, we don't have that nice feeling of we've come to the end of the road or we're hitting the wall. It feels like it still wants to go. And we call that a soft point. And, these are things that are very subjective. It's not objective. Everybody will feel these endpoints slightly differently, but I would say, don't worry if you're finding it difficult to grade the degree of laxity or the endpoint, but with time and experience, you will get better and better and better. And it's important to always remember, you can learn how to establish these endpoints and these degrees of translation better when the patient is asleep. So always spend time, examining that knee when the patient's under the anesthetic, because you get a really good feel for these endpoints. And it's the best place to teach your juniors as well. So I hope that helps explain that.
Yeah, that's very good. Thank you. There was also a question on the YouTube. One Dr. Paparao was asked, if you get a pivot positive in a post-operative phase complained by a patient after some months of surgery, what would you do? Take it as a pivot negative on table after ACL reconstruction.
Yeah, it's a very good point. Very good question. So we know from the literature that patients who have a persistent positive pivot shift test after ACL reconstructive surgery generally don't do very well. They're the patients that are going to have a bad outcome. So, taking one step back, usually those patients with a very strong pivot shift test, and I described it as an explosive pivot shift test. You do the pivot and it's a really big bang. Those are the patients that I would have a low threshold to plan in my surgical planning. I will be thinking, well, you know what? I'm going to potentially do a anterolateral ligament reconstruction or a modified lamere, i.e. I'm going to reconstruct the anterolateral side of the knee, because we know that the anterolateral side of the knee has a big influence on the pivot shift test. So also, to answer your question specifically, what would I do if I did an ACL and the patient had a positive pivot shift test? First of all, I would, okay, you've identified that, that's important. Now, you could have a positive pivot shift test when you examine that knee. However, that patient may not objectively say to you, you know what, doctor, my knee feels unstable. They may still feel stability within the limits of what they expect from their knee with day-to-day activity. So somebody who is not playing professional sport, someone who just likes to go for walks, maybe ride the bike, go to the gym, keep fit, for that patient, actually, you know what, you don't have an ongoing problem with the knee giving way. However, if it's someone who's getting back to sport and the knee is giving way, then that can potentially be a problem. So how are we going to address that? Well, the first thing we'll do is address the neuromuscular component to this knee. We have to make sure that this patient's rehabbed really well. You've really spent a lot of time building up their glutes, their quads, their hamstrings, their calf muscles. So a top-down strengthening, stretching, conditioning program. Lots of proprioceptive exercises. So working on proprioception to try and increase the muscle firing and recruitment of muscle, which may help further control this knee. Also, working on plyometric stuff to help, again, explosive movements to help get those muscles recruited, which may give a little bit of additional stability. Now, you have two options then if you have persistent instability. One is you can try and control the instability with resetting your patient's expectations and saying, well, your knee's unstable with these things. Well, maybe if you're happy to not do these things, maybe your knee will be okay. If the patient's happy, great, you're lucky. But if they're not happy, what are you going to do? Well, either you're going to try and control their instability with some kind of brace, okay, an external brace, it's just to help control that abnormal movement, which may give them enough stability to get back to some of their activity. Or I suppose you have to consider reconstruction. And if you are considering reconstruction, you would almost certainly, I would recommend that you add in an anterolateral procedure, such as a modified Lemaire or a anterolateral ligament reconstruction. Some people have described, although I've not done this personally, have described just adding in an anterolateral procedure to see if they can control the AP translation or rotational instability. It's not something I've done in my practice, but when you go to meetings, there are always one or two people who recommend that they've tried this, and sometimes it works, sometimes it doesn't. But I think most people would reconstruct the ligament and add in an additional procedure to the anterolateral side of the knee.
Okay. I have a question for you.
Assess ACL in an MCL injured knee.
How do you assess the ACL in an MCL injured knee? Okay, yeah. So I presume you're referring to a pivot shift test, because you need to have an intact pivot shift to perform the intact MCL to perform a pivot shift test. Now, almost certainly, I mean, most ACLs I see acutely have an MCL injury. It's usually a grade 1 sprain, possibly a grade 2. I think as long as there's an endpoint to the MCL, which you will have with a grade 2 injury as well, you can perform the pivot shift. It's not a problem. It's not an issue. The only time you'll find it difficult is if you have a significant grade 3 injury. Obviously, when you put valgus stress, the knee just keeps opening up. You just know that's a very unique scenario. You can't perform the pivot shift in that situation.
Okay, I have a question for you.
Yeah.
Does the beaten score?
The what? Sorry.
Okay, does the beaten score affect whether or not you will do extra-articular tenodesis?
Yeah, absolutely.
Even when you don't actually suspect an anterolateral ligament injury.
Yeah, absolutely. So that's a very good question. So increased Baton score, i.e. hypermobility. So patients who have hypermobility, we know that they have a higher incidence of graft failure and recurrent instability. So there are technical considerations you can use during your surgery in terms of tunnel placement, particularly on the tibial side, placing your tibial tunnel a little bit more posterior to avoid impingement of your graft in extension. Which graft you choose. So are you going to go for a hamstring graft versus a bone patella tendon bone graft where you have bone blocks on either end with better bone-to-bone healing, less chance of stretching of your graft? These are considerations. But also one of the indications for a anterolateral procedure like a modified Lemaire anterolateral ligament reconstruction is hypermobility. So for me in my practice, if I have a patient with significant hypermobility, I will routinely perform a modified Lemaire procedure.
Yeah, that's a beautiful answer. So there are a couple of things you can do when you have a higher Baton score. One is choose the graft properly, and then possibly have your tunnel slightly more posterior in the tibia, and maybe possibly add an anterolateral ligament. Yeah.
Yeah.
Yeah. Thank you. Dr. Srinivas, you have anything?
Are there any clinical indicators that would indicate conservative management for a patient?
Yeah, so clinical indicators for conservative management. I have to say, one of the biggest clinical indicators for conservative management, particularly in my hands, is a patient that's non-compliant. So if I have a patient who has an ACL injury, we've examined it, it's unstable, we've got the MRI, and they're pushing you for surgery, and you send them for physio, but they don't engage with their physio, then for me, that's a reason not to operate, because they're going to do badly post-operatively. We know that patients who do not engage well with their physio beforehand are going to do badly after surgery. So for me, that's one of the main indicators for not operating. Really, that's probably the main one.
Okay. And let's take an acute scenario. If a patient comes to you with hemarthrosis, and you're probably suspecting an ACL injury, how would you manage that patient? And the other question is, when do you do an MRI scan for confirming ACLs?
Yeah, that's a very good question, a very practical question. This is the scenario we face every day. So, you know, when you see an acute knee injury, you know, these knees are painful, they're limping, they often can't move the knee very well. And often you can't actually assess the knee sometimes. You can't do anything other than come to the conclusion that this knee is painful, it won't move, and it's swollen. So you have to go back to the basics at that stage. So you have to treat the acute knee injury with basic first aid things. So resting it, icing it, elevating it, a little bit of compression, maybe with a sleeve that you put around the knee to help control the pressure. Take the weight and the stress off the knee joint. So give that patient crutches immediately, just to offload the knee and tell them to weight bear as comfort allows, okay? It's important to keep muscle activation going, because if they stop using the quads, it withers away, it wastes very quickly. Within 48 hours is significant muscle wastage, and it's very difficult. You can never recover that. So tell them to straight leg raise, just simple things, just to keep the muscles activated. And analgesia, of course, is very important. One consideration in the acute setting, if you have a setting where it's safe to aspirate the hemarthrosis, you can consider, under aseptic technique, aspirating the hemarthrosis. This has a number of effects. It reduces the swelling, which helps improve pain. It makes the knee less tight, so the knee is more likely to be able to bend. But importantly, the hemarthrosis is it inhibits activation of the quadriceps. So by draining the hematoma, suddenly they can activate their quads, they can activate the muscle, they can straight leg raise, they can get that knee moving. So it has multiple effects. Plus, aspirating the blood tells you that, and often if you see fat in the blood as well, it may tell you there's a fracture. So, you know, it can give you a little bit of clinical information as well. So that's how I would manage acutely. And I would say to the patient, look, you go away, I'm going to see you in a week's time, okay? Because there's no point causing more pain to this knee, you know, trying to examine it, because you're not going to get meaningful information. Obviously, it goes without saying, you need to exclude a significant injury, such as a knee dislocation, make sure there's no neurovascular compromise to this leg, you know, and make sure it's safe to send this patient away. If it is, bring them back in 1 week, bring them back in 2 weeks, it's okay. Hopefully by then, the swelling will have gone down, they'll have less pain, and you can
give them a brace?
Yeah, sorry, I beg your pardon. Yeah, you can use a knee brace as well. So there are different types of knee braces. There are splints, which keep the knee straight. And often when patients come from the emergency department, they have their knee in a splint, and it's just holding their knee straight. That's a good temporary solution. You do not want your patients wearing that brace for 2, 3, or 4 weeks, because keeping that knee straight with a slight bend in the knee will cause a flexion contracture, tight hamstrings. You'll struggle to get the knee straight again. and it causes the quadriceps just to waste away. So temporary splinting is okay, and I would use one maybe for up to a week. However, a hinge knee brace is a better option, or an ACL specific brace if you suspect an ACL injury is a better device, because they can at least get their knee bending, maintain movement. So when you bring them back at a second stage, 1 week later, 2 weeks later, you can examine, you get a better idea of what's going on. Then at that stage, if your clinical suspicion is for ACL rupture, meniscal tear, just send them for an MRI scan. Then within a couple of days, you'll have the diagnosis. And then you're still within a very good time frame to make a further, more specific management plan for that injury. So for example, it may not be an ACL, it might be a bucket handle tear of your meniscus, but you haven't lost much time at all. You can bring them in and repair that meniscus or do whatever else you need to do. So don't worry about sending your patients away and bringing them back again. Serial assessments will give you more clinical information each time, which will help you just change your management. But obviously, if your patient is struggling, send them for an MRI scan. I mean, sometimes at the initial presentation from the history, like I said in my talk, 90% of the diagnosis is in the history. If you think that this is a significant soft tissue injury, just refer them for the MRI. But again, bring them back in a week or two to re-examine them. That's okay.
Okay, that's good. Thank you.
I think that was a beautiful answer and a beautiful session also. Dr. Srinivas, do you have any other questions for him?
Well, maybe if you can tell us, you showed preoperative examination under anesthesia. If you can tell us the order in which you examine during EUA,
Sure.
That would be great.
Yeah. Okay. So my order, my roadmap when I examine a knee is, first of all, the first thing I do is I check the range of motion. So I always assess the normal knee first. So I showed you the examination of the injured knee, but the first thing I do is I don't even touch the injured knee. I go to the normal knee, the uninjured knee, and I will assess range of motion. The first thing I will do is check for hyperextension. So how much hyperextension is there present in the normal knee? Because if we do not get this hyperextension back on the injured side, the injured knee after reconstruction will never feel like a normal knee, and the patient can be disappointed. So always check for hyperextension and document that. I then check foot flexion on the uninjured knee. The next thing I will do is I will assess in order the ACL, because that's my favorite thing. So I will, you can do it in any order, but I take the ACL, so I'll do an anterior Lachman, then I'll do an anterior drawer, then I will do the pivot shift test. So that's my 3 tests for the ACL done, okay? I will then bring the knee sorry, I beg your pardon. I'd say that again. I do my anterior Lachman, I do my pivot shift test, then I bring the knee into 90 degrees and I do my anterior drawer test. Whilst I'm there, I also palpate the anterior medial tibia just to make sure I can feel that step off. It's called the step off. And if you can feel that, it means the tibia is not sublux posteriorly. So if you examine a knee that has a PCL injury with the tibia sublux posteriorly, you cannot feel the anterior medial tibia. So for me, that's like a quick assessment just to see the PCL, is that okay? But then I also do a posterior drawer to test the PCL. I will then bring the knee into full extension and I will test my MCL in extension and in 30 degrees of flexion to test different components of the medial stabilizers. I will then test my lateral collateral ligament and then bring the knee into that figure of 4. And I like to palpate the lateral collateral ligament just to make sure that I can feel it. It's a really obvious band of tissue and you can palpate it. If you don't do this routinely, I recommend that you do it in all your patients. You will start to feel the lateral collateral ligament and get an appreciation for that. And I think that's pretty much it. That's then I do the dial test, sorry, to check for the posterolateral corner. So I will do the dial test again at 90 degrees first, and it's easier with an assistant on the other side. You bring the heels together and then you externally rotate the feet. And you look for, if there's more than 10 degrees more external rotation, that indicates there's a problem, okay? And if it's just at 90 degrees, it usually means there's a PCL injury. However, if it's at 90, but also at 30 degrees, there's increased external rotation, it means it's a posterolateral corner injury, okay? So do it at 90 and at 30 degrees. And that really concludes my examination under anesthetic. Sometimes I will also examine the patellofemoral joint if I'm suspecting that there is patellofemoral instability. I will see how much a lateral translation there is of my patellofemoral joint in extension and 30 degrees of flexion. And that usually concludes my EUA.
Okay.
Mr.
I have
Tahir,
a
what
couple
is
of
your opinion?
questions.
I'm
Yes.
sorry. What is your opinion about doing the dial test in prone position?
Yeah, so I mean, doing it in the prone position is convenient, in my opinion. Okay, doing the dial test in the prone position is very convenient because you don't need an assistant. You can do it on your own. You just get the patient lying flat, flex their knees up to 90, and you rotate both the knees at the feet, and you can see if there's a difference. And yes, you can pick up abnormalities that way. However, if there is a posterior medial knee, a soft tissue injury to the posterior medial complex, you can get a falsely positive external rotation of the knee with the patient lying in the prone position. So you can get a false positive dial test in the prone position. Whereas in the supine position, with the ankles together, the knees together, you're less likely to get that. So I think in the supine position, it's more accurate, in my opinion.
Okay. And you were talking about regaining the extension that
Yes.
is available on the normal side. In relation to that, I would like to ask you a question. What is the position of the knee in which you tighten the fixation on the tibia? It's like in flexion.
Fixing my ACL graft. Yeah. So
in the ACL graft.
I try to go for approximately, certainly no more than 15 degrees of flexion, no more than that. So roughly 15 degrees. And I use a posterior Lachman when I'm securing the graft. On occasions, I fix the graft in extension as well, to be absolutely honest with you. And I think if I'm concerned about that patient getting their extension, I'll probably fix it closer to extension. If they have a very hyperlax knee, I certainly will fix it with some degree of flexion.
Okay. You would
What,
like to
what
take
if the
it
patient
to
is
subject to
hyperextending on the other side?
Yeah, if they're hyperextending on the other side, I mean, Shri, what I think most of us would agree is that, obviously you want to try and get that hyperextension back. But, the fact of the matter is, if that knee is hyperextending a lot, then that risk of graft rupture is significant. So in some ways, it's protective for the graft not to get the hyperextension. So if they lose a little bit of hyperextension, say they had, 15 degrees, 10 degrees of hyperextension, but actually they end up with 5 degrees of hyperextension, I think that's protective for the graft. Or if they end up in neutral, they're not going to be perhaps as happy, but the trade-off there is that you're protecting your graft a little bit. And I think, that's a bit of a trade-off. But, like I said, if they've got a lot of hyperextension, I'll fix the graft in flexion and about 15 degrees of flexion with a posterior Lachman applied.
Sasi, you want to ask something? There are a couple of questions on YouTube, actually.
Okay.
When do you start to weight bear after your ACL reconstruction? And when do you expect your patient off the brace? Do you give a brace? And when do you allow full weight bearing?
Okay, good questions. So you may have to remind me if I forget one of them. But first of all, I do my ACL reconstructions as a day case procedure. So all my patients go home the same day. I give them crutches. They're fully weight bearing in crutches from day one. I don't partial weight bear them, even whether they've had a BTB or a hamstring. It doesn't make a difference to my practice. They go fully weight bearing straight away. I give them an extension splint only to wear at night for the first, maybe up to the first 5 days, maybe up to the maximum the first week, only at night. And that's only to keep the knee in extension, so that they feel, particularly with a hamstring graft, to just feel more comfortable having that knee in full extension, so they don't develop a little bit of an extension deficit. But to be honest with you, in my practice, I don't use braces post-operatively. And if you look at the literature on bracing post-ACL reconstruction, really the literature doesn't support routine bracing in the post-op period. So I do not routinely brace, although, like I say, I give them an extension splint and I tell them to wear it at night, possibly up to the first week, and then they absolutely get rid of it. But they're fully weight bearing straight away. And I just want them just to fully weight bear, and I want them to start moving and bending that knee and getting that knee straight as soon as they can. So getting back range of motion and weight bearing on the knee for me is an important thing that starts straight away.
What are your criteria for discharge? You said you're doing as a day case.
Yeah.
So what are your criteria to discharge a patient on the same day?
Okay, so the criteria for discharge are, first of all, it had to be an uncomplicated procedure. That wasn't a complex procedure with additional procedures. If it's a lengthy surgery, then we had to do extra stuff because it wasn't just an ACL, a straightforward ACL. Then maybe I'll keep them overnight. But generally speaking, for routine ACL, even with lateral modified lamella procedure and meniscal repair, they go home the same day. They have to be comfortable, first of all. So pain has to be well controlled. Secondly, they have to be safe on their crutches, and that's usually an assessment that's done by the physiotherapy team. They'll get them up on crutches, they'll get them mobilizing, and like I said, we give them that extension splint to be worn at night for the first few days, but they can keep it on for the first couple of days just to help them when they, particularly the first day when they go home, just to keep the knee straight and prevent that knee from collapsing on them, if they have pain or something. So it just gives them a little bit of extra confidence. But really, it's a physio assessment and it's a pain assessment. And if they are comfortable and they're safe on their crutches and everything else was fairly routine, then I'm happy for them to go home.
So is there somebody visiting the patient at home after discharge?
No, there isn't. So we don't routinely visit the patients at home after discharge. So they go home the day of the surgery. They will come back within the first week for a physio assessment. So the first port of call, the first person to see them in the first week will be a physiotherapist. And that's usually around the fourth day or so. And the reason for that is just to make sure that they're comfortable, they're working on extension, they're getting the knee moving, the swelling is coming down nicely. So they've been, icing the knee and they're happy. And to go over the rehab plan with them. I personally see them for the first visit. Then they have a wound check at 2 weeks. And again, I don't personally have to do the wound check. It can be done by any other qualified person. I will see them at 4 weeks after the surgery.
Okay. So do you give thromboprophylaxis during ACL?
So I'll be honest with you, I don't give thromboprophylaxis for ACL routinely. And I hadn't done for probably about 6 years. But recently we've had some new guidelines in the UK regarding thromboprophylaxis for non-arthroplasty work. And if the surgery is, the average time for surgery is less than an hour for, a straightforward ACL. So for me, I don't give thromboprophylaxis for those patients because they're fully weight bearing. They're moving their ankle. The surgery wasn't particularly long. So in my opinion, in my practice, and based on what I've read and my experience, I don't give thromboprophylaxis. However, if, for example, I'm doing a meniscal repair or we've done some articular cartilage surgery and we've got the patient non-weight bearing, or we've put them in a hinge knee brace and we're gradually increasing flexion, I will consider giving them thromboprophylaxis in cases where there's restricted movement post-operatively, or if the length of surgery was more than an hour and a half, then in my practice I give thromboprophylaxis and I use low molecular weight heparin.
Okay. Sasi, do you have any questions?
No.
Is that similar to your practice in India? I mean, what do you guys do? I'm curious to know.
Or we don't give thromboprophylaxis as well here.
Okay.
Incidence is very low here. So
yeah, I mean, because people just get on with things, don't they? And I think that's a cultural thing, possibly. But here, in other countries, it's not always.
When I was in the UK, I see the difference compared to UK and India. The incidence of thromboembolism is very low.
Right. Okay. Yeah. I'm not surprised.
Yeah, I too never give thromboprophylaxis, and even in total knee replacements, if we are able to mobilize the patients, then we most of the time don't give.
Sure.
Otherwise, if it's like a heavy patient who's like older, heavier patient who's less mobile, then that is when we actually give. That is for a knee replacement, but in arthroscopy, almost none.
Okay, that's good.
Okay, I think it was a wonderful session. It was a very clear session explaining a lot of questions, and your presentation was very clear too. I thank you very much for making it clear for.
You're welcome. It's been a pleasure. I've really enjoyed it. Thank you for giving me the opportunity.
Thank you very much. Thanks a lot.
Wishing everyone in Oman and India, wishing you guys all the best.
And we also have a lot of people from around the world joining us today.
Oh, really? That's interesting. It'd be good to know where the people are listening in from at some point.
Okay.
Maybe you
So
can
I
ask
hope,
you to talk on Day Case ACL sometime.
yeah, I really
Yeah,
hope
no
to,
problem. It'll be a pleasure. Yeah,
yeah,
we can do that.
I really hope to call you again for some other topic.
No
We
problem.
want to
Pleasure.
make, we want you to make some complicated topic very simple.
Okay, I'll try my best.
Okay.
Okay.
It was nice
Take
meeting
care.
you.
All the
Thank you.
best. Take care. Thank you.
Take care.
Bye.
Thanks a lot. Bye.